Today, we're diving into something really vital, impacting lives all over the world, organ donation. And specifically, that really tough, ongoing problem of organ shortage. For years, one of the biggest hurdles, maybe the biggest, for using organs from deceased donors has been the fear of infectious diseases.
Hmm.
If a potential donor had certain infections, it was often just an automatic no, a full stop.
A deal breaker.
Exactly. But here's where it gets really interesting, because what used to be an absolute barrier is now, well, incredibly often a go with care. It's a huge transformation in medicine, and that's exactly why we're doing this deep dive today.
Precisely. And in this deep dive, we're going to unpack just how these incredible advances in, well, medical science, diagnostics, treatments,
Yeah.
how they've radically reshaped the whole landscape of organ donation. We want to show you how organs that, were once considered completely unusable are now becoming viable options. The mission here is really to illustrate how this evolution is safely expanding the donor pool and ultimately offering life-saving transplants to more people than ever before.
Okay, let's get into it. Now, despite all this amazing progress we're about to talk about, it's important to start by saying some infectious diseases still remain absolute no-goes for donation. Right.
Absolutely. That's right. We have to acknowledge that.
Yeah.
These are situations where the risk to an immunocompromised recipient, someone whose immune system is suppressed for the transplant, is just too high. Often the consequences are untreatable and, frankly, devastating.
So the risk just outweighs any potential benefit.
Overwhelmingly, yes.
Mhm.
The risk-benefit calculation still strongly favors not using the organs in these specific cases.
Mhm.
Recipient safety has to be paramount, for instance, active untreated rabies or prion diseases.
Like CJD?
Exactly, like variant CJD or sporadic CJD.
Hmm.
These are invariably fatal. There's no effective treatment. So the danger of passing them on is it's unacceptable.
Makes sense.
Similarly, active untreated viral encephalitis or meningitis, infections attacking the brain and spinal cord, they pose a very high risk of devastating transmission to the central nervous system.
Right.
We also see absolute contraindications with disseminated or untreated invasive fungal infections.
Yeah.
These are just extremely difficult to get rid of post-transplants, especially in someone who's immunosuppressed.
Okay.
Untreated disseminated tuberculosis is another big one. High transmission risk, and TB is already notoriously tough to treat. And finally, untreated sepsis, especially with pan-resistant organisms, bugs resistant to nearly all antibiotics.
So no fallback treatments.
Exactly. We simply lack effective treatment options for the recipient if they were to get that infection. These are really the lines we still can't safely cross.
That gives us a really clear picture of what's still absolutely off limits. But the real story here, the one offering so much new hope, is how the vast majority of infections, things that were once absolute barriers, are now, well, manageable, considered relative contraindications.
Relative, meaning donation is possible with careful evaluation.
And this incredible shift, it's driven by a few key things, right? You mentioned diagnostics.
Yes, primarily highly sensitive molecular diagnostics like nucleic acid testing or NAT.
That's looking for the virus's genetic material itself.
Precisely. It's incredibly specific. Then there are potent new antimicrobials. Think of the direct-acting antivirals for hepatitis C. We also just have a much better understanding of the actual transmission risks and, importantly, much improved ways to treat the recipient if transmission does occur.
So where should we start with this evolving landscape? For me, the most compelling story, maybe the prime example of this revolution, has to be hepatitis C virus, HCV.
Oh, absolutely.
The arrival of those highly effective, well-tolerated, direct-acting antivirals, the DAAs, these drugs that directly attack and clear the virus. It seems like they fundamentally changed everything.
It's astonishing, truly. What's fascinating is that NAT-positive, or viremic donors, meaning the virus is actively replicating in their blood, are now, well, routinely used.
Routinely, even with active virus.
Routinely. We have really impressive results from big studies like Thinker and Expander and also from large registry data. These show that recipients, whether they were HCV negative to start or already had HCV, when they get an organ from an HCV viremic donor and are treated with DAAs, they achieve sustained virological response rates, basically a cure of over 95 to 98%.
Over 95%? That's practically a guarantee of clearing the virus. It almost sounds too good to be true.
It's remarkable.
I can only imagine the relief for a patient who maybe just a few years ago would have been told no because of a donor's HIV status and now gets this second chance. This isn't just a number. It means hepatitis C, once a definite no, is now a pathway to life for thousands. It's dramatically expanded the pool of available organs.
It truly has. And the management strategies are quite robust now. It always starts with universal NAT screening for all potential donors.
Okay.
Then, critically important, is informed consent, a really transparent discussion with the recipient about the specific risk of getting HCV and the plan for DAA treatment.
And how does that treatment work? Do they start it right away?
Well, there are two main approaches. One is prophylactic, meaning we start the DAAs very early, sometimes even before we confirm the recipient has the virus, just to be proactive.
Prevent it before it starts.
Right. Or there's the preemptive or therapeutic approach, where we monitor the recipient closely and only start DAAs if we actually detect the virus in their blood after the transplant. Both are highly effective, though the prophylactic route might slightly reduce transmission risk, perhaps at a higher initial cost.
And this isn't just for kidneys, is it?
No, not at all. Kidneys, livers, hearts, lungs, they're all now routinely transplanted using this HCV-positive donor approach.
It's incredibly versatile.
Amazing. Okay, let's turn to another big one, hepatitis B or HBV. That's also seen some significant changes, hasn't it? Donors who test positive for just the core antibody, the anti-HBC positive ones, showing past exposure. They used to be largely avoided too, but now they're frequently used. Yes, frequently used, especially for recipients who are already immune to HBV, maybe from vaccination or past infection, or for those who are already HBV infected themselves. Nuance is really the key word with HBV.
Nuance, how so?
Well, the biggest challenge, and where we've made progress, is in refining the risk assessment. We use enhanced serology alongside NAT testing. These are critical to distinguish between different HBV statuses, like past result infection versus low-level or occult viremia, where the virus might still be hiding at low levels.
Ah, so you can get a much clearer picture of the actual risk.
Exactly. It allows for a much more precise call on whether using the organ is safe and what precautions are needed.
And the management for the recipients sounds equally refined.
Yes. For HBV-naive recipients, those who've never had HBV lifelong potent nucleoside analog therapy, those antiviral drugs that stop replication is usually essential. Sometimes hepatitis B immunoglobulin or HBIG is added too. And we even consider pre-transplant vaccination for candidates on the wait list to try and get them immune before transplant.
Interesting. Proactive again.
And connecting this to the bigger picture, there's an important distinction between liver and non-liver organs with HBV. Livers from donors who are HBsAg positive, meaning they have the surface antigen indicating active infection, carry a higher risk.
Okay.
Those are primarily used for recipients who already have HBV. But non-liver organs like kidneys or hearts from these same donors carry a lower risk if the recipient gets appropriate antiviral prophylaxis. This careful stratification lets us use more organs safely.
Right, balancing the risk carefully. Now, shifting gears again, maybe one of the most surprising expansions, certainly in recent years, is with HIV, human immunodeficiency virus. That was always considered an absolute contraindication. But now, HIV-positive donors are actually utilized.
Yes, under specific protocols, primarily for recipients who are also HIV positive. This is often called HIV to HIV transplantation. It was really enabled by a key piece of legislation in the U.S., the HOPE Act, the HIV Organ Policy Equity Act.
HOPE Act, okay. And how are the outcomes? Is it safe?
The outcomes so far are really quite encouraging. In carefully selected cases, patient survival and the survival of the transplanted organ, the graft survival, are comparable to what's seen when HIV-positive recipients get organs from HIV-negative donors.
Wow.
Now, transmission of the donor-specific HIV strain can happen, but it seems to be a manageable risk. It usually requires adjusting or intensifying the recipient's antiretroviral therapy, their RT, and very close monitoring. But it means we can offer life-saving transplants to HIV-positive patients who, for so long, had very, very limited options.
That really is a huge breakthrough. Offering hope where there was little before, it must require really strict criteria for the donor, though.
Absolutely. Very strict. The donor typically needs to have an undetectable HIV viral load while on antiretroviral therapy, no current opportunistic infections. Those infections that take advantage of a weak immune system and a good immunological status, generally meaning a CD4 count above 200 cells per microliter.
And for the recipient,
Crucial recipient management involves them being on stable RT with their own HIV viral load undetectable before the transplant. Then post-transplant, very careful monitoring is needed, specifically looking for any signs of the donor's HIV strain and, of course, the essential role of a multidisciplinary team overseeing everything.
right, and using organs from HIV-positive donors for HIV-negative recipients. Is that happening?
That remains highly exceptional. It's really still in the realm of clinical trials and research, not standard practice. The focus right now is safely expanding options for HIV-positive patients first.
Okay, that makes sense. So we've covered the big three viruses, HCV, HBV, HIV. But beyond those, many other infections, common viruses like CMV or EBV, bacterial infections, fungal issues, they were all once potential barriers too. What's the general approach now that makes using organs from these donors possible?
That's a great question because the principles we apply are actually quite similar across the board. It's about understanding the specific risk and having a plan. For other common viruses like cytomegalovirus, CMV, or Epstein-Barr virus, EBV, the donors and recipients status, like a donor being positive, D+, and a recipient being negative, R, that's recognized as a risk factor, definitely.
But not an absolute no.
Exactly, not a contraindication. It's managed usually with antiviral prophylaxis, giving preventive medication, or sometimes preemptive therapy, where we monitor closely and treat only if the virus reactivates.
Okay. And what about newer challenges like COVID-19, SARS-CoV-2?
Right. Well, the current understanding is that organs from donors who had COVID-19 but have recovered, meaning they have a negative NAT test for the virus and their symptoms are gone, appear to be safe to transplant. There's some special consideration for lungs. Yes. Techniques like ex vivo lung perfusion, where the lung is assessed and even treated outside the body before transplant, are being explored, often combined with PCR testing of the fluid used to be extra sure there's no active virus lingering.
And bacterial infections. You mentioned rapid diagnostics earlier. Is that the key here?
Absolutely. It's a game changer. Yeah. A history of treated bacteria in the bloodstream is not an absolute contraindication anymore. Rapid diagnostics like multiplex PCR, which can quickly test for many different bacteria and viruses at once, and MALDI-TOF mass spectrometry.
MALDI-TOF.
Yeah, it identifies bacteria based on their unique protein fingerprint. These tools give us incredibly fast organism identification, sometimes in hours instead of days. That speed is vital.
So you know what you're dealing with much faster.
Precisely. Management then focuses on knowing the specific bug, making sure the donor receives adequate antibiotic treatment, controlling the original source of the infection if possible, and then giving targeted prophylaxis to the recipient. Even for some multidrug-resistant organisms, MDROs, careful assessment and planning can allow for organ use in selected cases.
And TB, you said active untreated TB is a no, but what about other cases?
Right. Active untreated disseminated TB remains absolute. But donors with latent TB, where the bacteria is dormant, or a history of adequately treated TB, those organs can often be used. But it requires careful risk assessment and usually involves giving the recipient specific anti-TB prophylaxis for a period after transplant.
Okay. What about fungal and parasitic infections? They often sound quite tricky.
They can be, but again, management strategies exist. For fungal infections, a history of an endemic mycosis, like histoplasma found in certain regions, if it was properly treated in the donor, is generally acceptable. Recipient prophylaxis might be used if the risk is deemed higher.
And parasites, like Chagas.
Yes, Chagas disease is a good example. Donors who are seropositive are increasingly being utilized, especially in areas where Chagas is common. This involves careful pre-transplant screening of donors and recipients, thorough informed consent, close post-transplant monitoring for the parasite, and preemptive treatment if it's detected in the recipient.
I see.
For others, like strongyloids, another parasite, there's a risk of hyperinfection in immunosuppressed patients. So donors who test positive generally need documented adequate treatment, or there needs to be a clear plan to treat the recipient proactively. And for toxoplasma, another parasite, the main concern is a donor-positive recipient-negative situation, D+R, especially for heart transplants.
Why, especially hearts?
Toxoplasma can cause myocarditis, inflammation of the heart muscle. So in that D+R heart scenario, prolonged prophylaxis for the recipient is standard practice. The key across all of these bacterial, fungal, parasitic is really precise identification, assessing the treatment the donor received, understanding the recipient's risk, and having tailored preventative or preemptive strategies ready.
It's truly amazing, the level of detail and planning for each specific challenge. But as you've hinted, this isn't just about individual breakthroughs for each bug, is it? There has to be a bigger system, a framework that makes sure all this newfound flexibility is managed safely and effectively. What's that crucial underlying infrastructure? How does it all actually work together?
You've hit on a really key point. It absolutely is a system, a collaborative effort built on several foundational pillars working together. First, you have enhanced donor screening. This isn't just a quick check. It's a comprehensive review of their medical history, social history, a thorough physical exam, plus detailed lab results and imaging findings, getting the full picture.
Okay, deep dive on the donor.
Exactly. Then there are the advanced diagnostics. We've talked about universal NAT for HIV, HBV, HCV is standard now. Serology tests for other key pathogens like CMV, EBV, toxoplasma, strongyloids, Chagas, depending on risk factors. And those rapid microbiological ID techniques for bacteria and fungi.
Faster and more comprehensive testing.
All right. Next, and this is crucial, are pathogen-specific protocols. These aren't just suggestions. They're often detailed institutional or national guidelines. They lay out exactly how to screen, how to assess the risk for a specific infection, what needs to be in the informed consent, what prophylaxis or preemptive therapy the recipient should get, and how they should be monitored afterwards. Tailored plans.
And you mentioned informed consent being critical.
Non-negotiable. Absolutely non-negotiable. This has to be a transparent, detailed discussion with the recipient, explaining the specific potential risk of transmission, what the management plan is, what the potential complications might be, and what the alternatives are, including potentially waiting longer for an organ from a donor without that specific infection history. It's about empowering the patient to make a truly informed choice that aligns with their own tolerance for risk.
That sounds vital for patient autonomy.
It is. And perhaps the glue holding it all together is the multidisciplinary team approach to MDT. This is the vital collaboration between the transplant surgeons, infectious disease specialists, the organ specialists like nephrologists or cardiologists, transplant coordinators, pharmacists, sometimes ethicists, all bringing their expertise together for these complex evaluations.
Like a specialist team huddle for every complex case?
Pretty much. They collectively weigh every factor: the donor status, the recipient's condition, the specific organ, the available treatments. And finally, underpinning all of this is vigilant post-transplant monitoring. This isn't just hoping for the best. It's actively looking for any signs of potential donor-derived infection through regular clinical checks, targeted lab tests like NAT or PCR when needed, and importantly, reporting any suspected or confirmed transmissions to national registries, like the OPTN's Donor-Derived Infection Transmission System in the U.S. This helps track outcomes and refine protocols over time.
It really paints a picture of a system built on rigor, collaboration, and constant learning. It's clear this whole process is a triumph of meticulous science and really dedicated teamwork. As we push these boundaries, though, what does the future hold? Where is this field heading next?
Oh, the future horizons are incredibly exciting. We're looking at the development of even faster, more comprehensive pathogen detection methods. Things like next-generation sequencing, metagenomics.
Metagenomics?
Yeah, basically technology that could potentially identify all the genetic material, viral, bacterial, fungal in a sample, even unknown or unexpected pathogens, maybe almost instantly. That could revolutionize screening.
Wow, okay.
There's also ongoing work to optimize the prophylactic and preemptive drug regimens, finding the sweet spot for duration, dosing, minimizing side effects, and considering cost-effectiveness.
Fine-tuning the treatments?
Exactly. We also need more long-term outcome studies for some of the newer practices, like using organs from HIV-positive donors, just to confirm the excellent short and medium-term results hold up over decades. And researchers are exploring the potential use of organs from donors with other viruses, like hepatitis D or E, which we haven't routinely used yet.
Still more frontiers to explore.
Definitely. Plus, developing more refined risk prediction models, maybe using AI or machine learning, that can incorporate dozens of donor, recipient, and pathogen factors to give an even more precise, individualized risk score. And finally, working towards greater global standardization of guidelines so these life-saving practices are applied consistently and safely everywhere. The goal is always to get safer, faster, more efficient, and ultimately transplant more people successfully.
This has been such an illuminating deep dive, really understanding how this field has moved from rigid rules to such nuanced, careful decision-making.
I think the central message here, really, is that the landscape of infectious disease contraindications in organ donation is just incredibly dynamic. It has fundamentally shifted. We've moved from a place of almost categorical exclusion for many infections to a much more nuanced, individualized evaluation. It's not a one-size-fits-all anymore. It's become a, what's the specific risk here, and how can we best manage it safely for this donor organ going to this recipient approach?
And what this all means for you, the listener, is profound. It means more life-saving transplants are possible now, and they're being done safely thanks to these groundbreaking scientific and medical advances, and, just as importantly, meticulous teamwork.
Mhm.
So consider the ripple effect of this progress. Think about how this constant push for innovation, this refusal to accept old limitations, means that for so many people, what was once an impossible dream of a second chance at life is actually becoming a remarkable reality. Which leads to a final thought. What other areas of medicine do you think might be on the cusp of a similarly transformative shift right now?